I'm Dr. Jam Kothari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family. Hi Jam, lovely to see you. So here we are, another podcast on treatment for patients who've been newly diagnosed. This time we're going to focus on the older patient population, or those who aren't having a transplant. But before we launch into that, what's new? Anything new from the world of myeloma to share with our listeners, or indeed your day-to-day life?
All going well, thank you, Sally. We're shortly coming up to a big European meeting next week, so I'm looking forward to going to that and hearing about latest advances and new treatments and things that can hopefully help our patients immediately, as well as the things that we may be seeing more of in a couple of years. I'm looking forward to seeing you at that meeting, so that would be great.
Yeah, well, we're going to test your ice cream theory, aren't we?
Yes.
One ice cream a day is work, more than that. So I'll be keeping a beady eye on your gelato intake, Jam. Watch out.
Keep tuned to hear all the updates, but we are going to Italy, so my plan might not work. But anyway, from ice cream to myeloma, it feels like an unfair way to move. Today does follow on, doesn't it, Sally, from the last pod? We're talking today about initial treatment for people who are not planned to have a stem cell transplant. We're going to focus primarily on what we do in the UK. But broadly speaking, Sally, what do we do and what are our aims?
So our aims in the people who aren't eligible for a transplant are very similar to those younger patients. It's all about controlling the disease to enable the body to get stronger, particularly if there's been complications from the myeloma. And as it gets stronger, to keep the myeloma under control for as long as possible. So broadly same aims. The key difference is there's no transplant as part of the pathway. And the drugs are pretty similar as well, fewer drugs, but in the similar vein to the transplant pathway, you continue on treatment until your disease comes back, which in the majority of people, it does eventually.
So as things stand in the UK at the moment, it's a 3-drug combination that is what we call a standard of care. And certainly throughout a lot of the world, that is the same. I think before we get into that, we should say that there are now 4 drug combinations for this group of patients as well that are not routinely available. But certainly for some groups of our stronger older patients, we will be moving towards maybe using a 4-drug combination at some point within the next couple of years. And we'll talk about that, of course, when it becomes available. But what is the 3-drug combination, Sally? And then let's go through that.
So as we said with our previous pod, we love the alphabet. Letters they really work for us. So the 3 drugs we call DRD. 2 Ds in there, a little bit confusing, but each letter stands for a different type of drug that you have at different times during each block of treatment. And just to remind everybody, a block of treatment is a treatment that you receive for a certain period of time. Often it's 4 weeks, and it is in this case, and we actually also refer to that as a cycle. So the first D, stands for Daratumumab. The R actually stands for a drug that can be called Revlimid, but we tend to refer to that drug as Lenalidomide. And the last D is Dexamethasone, our greatest friends and allies, those steroids.
Let's start with the first D, Daratumumab, Sally. So this is a type of drug called an antibody. It's a drug that's given as an injection under the skin. And initially when we give it, it's given weekly for a total of 8 doses. Then it's given every other week for a total of 8 doses. And then it's given once a month. It's a very effective drug and is a key part also of the treatment combination of patients that are having a transplant. Together with the Daratumumab, you get medication to reduce the chance of getting an allergic reaction, which can happen the first time it's given. And the medication that goes alongside Daratumumab helps to reduce the chance of a reaction. And typically drugs such as paracetamol, an antihistamine, and another type of drug is given for the first few doses, is a drug called Montelukast. Lots of names, but essentially these drugs minimize the chance of a reaction, which is relatively rare now that this injection is given under the skin, because a few years ago we used to give it intravenously, and then that was more of a risk. So in this combination, there is actually only one chemotherapy injection, as it were, and that goes under the skin.
Absolutely. And it tends to be pretty well tolerated, this treatment, actually. And we use it in other parts of the myeloma pathway. And there's at second line, we can use it just by itself, and indeed at fourth line. So when people relapse later, and when patients are receiving it by itself, sometimes they say, actually, it almost feels like they're not on any treatment at all. They're so well. So this is a drug where it's a fiddle to come up for it, particularly once a week and then once a fortnight, but it does get easier. So the next drug that people have as part of this treatment, this cycle, is lenalidomide, and that's the R bit of the DRD. Now, this is a tablet that we've been using for years, haven't we, Jam, to help control the myeloma in our patient population. And this is a tablet. It is prescribed to be taken every day for 3 weeks out of 4. So people tend to get into the swing of remembering when to start it and when to stop it. And often, particularly for older people, it can be useful actually to have it written down, the days in which you're taking it, and when to pause it.
Yeah, lenalidomide is one of the best drugs that we have, and is a scaffold for so many different combinations of myeloma treatment. But it does have side effects, especially at the beginning. Rash can be a problem. It's normally something that comes on when people start it, and it's one of these things that does go away, and then you can normally restart at a lower dose. But it can be quite problematic and quite florid, as we say. Other side effects, cramps, can be quite common, and often people don't realise it's because of the lenalidomide, and it is something that, as myeloma doctors, we should really ask all our patients on lenalidomide whether they're getting cramps, and they can be more at night, or they can be in your hands or your feet or anywhere really. And things that can help mitigate that are things like making sure you stay quite hydrated, tonic water, and there are other interventions that can help as well if they do become problematic, like changing the dose, for example. Fatigue, so tiredness, is a side effect, unfortunately, of any treatment, but it can happen with lenalidomide. And bowel disturbance, so diarrhea, is a side effect which tends to come on after people have been on the lenalidomide actually for a number of months. It's not normally an initial side effect. And then a very important one not to forget is that lenalidomide is in this class of drugs called immunomodulatory agents, and they increase the chance of blood clots, which can certainly be a big risk, especially at the beginning when people may be less mobile because of pain. And to reduce the risk of blood clots, we give a blood thinning medication when people are on lenalidomide. One of the major side effects of other myeloma drugs, which we've spoken about, neuropathy, is not normally a big problem with lenalidomide. And one of the really great things about this DRD combination, Sally, isn't it, is that neuropathy is not normally a big feature at all.
Very occasionally, people might present to clinic with a degree of neuropathy before they've even been told that they've got myeloma. And very occasionally, they might notice a change in their symptoms. But by and large, this isn't a problem with this regimen, which is great because neuropathy is a bit of a pain in the neck to manage, but most importantly, to live with.
So we're down to the second D. We always scroll back to steroids.
We always scroll back to steroids. And steroids, as we've said, are our friend and our foe in equal measure. Just to remind all our listeners about these side effects, the list is pretty scary when we go through it because it just feels like there's no part of the body which is unaffected by the steroids. But it's really important to say not everybody gets steroid side effects, but also particularly with this regimen, increasingly we are learning that you don't need to stay on the steroids long term. And in fact, you perhaps could drop the doses or even stop the steroids, certainly within the first year, maybe even a lot earlier than that.
Sally, I think an important question is, we talked about the drugs. So how long is this treatment for? Is it for a fixed length of time, or is it given for 1 year, 2 years, longer?
So this treatment in the round, so the DRD regimen, is given until your myeloma comes back. Now, when we try and predict when that might be, we have to look at what's been suggested in clinical trials. And the clinical trial data suggests that if you were to take 100 people and sort of line them up at the time of which they predicted, the 50th person, so what we call the median time to progression, is about 5 years. So 50% of people might progress prior to 5 years, 50% of people will be on treatment for even longer than 5 years and hopefully be feeling very well and in a good remission. So it works for a long period of time. That's really the message. And we prefer people to stay on this treatment until the myeloma comes back, but they don't need to stay on necessarily the exact same treatment that they started with in terms of the intensity or the drug doses.
It's a long time that we can control the myeloma for, right? Which is absolutely superb, but it's also a long time on treatment. And we know that this combination of drugs, generally is tolerated well. But if we think about our patient that is on this combination, we've talked about some of the original and initial side effects that you get with the 3 drugs. What else, Sally, do people need to look out for in terms of side effects and risks? 2 key things that anyone starting chemotherapy always asks is, will these drugs make me feel sick? And what is my risk of infection?
Yeah, so we tend not to see sickness with this regimen or feeling sick, which is reassuring, not least because actually steroids can help control the feeling of sickness. It's one good thing that they can do. And lenalidomide is related to thalidomide, which was initially produced to combat sickness, actually. So sickness isn't really an issue. And then infection can be an issue, particularly if perhaps the dose of the lenalidomide is a little bit more than you need. But by and large, actually, once your myeloma is under control, the risk of significant infection decreases. Your risk of infection is greatest when your myeloma is untreated. So treating the myeloma, controlling that disease, enables your immune system to actually get stronger, even if you're requiring treatment to do so. And so your risk of infection should be lower. But seasonal coughs and colds, they come around. Everyone gets them. We can't say to our listeners that you're not going to get infections. Of course you will. But I think the important message is they need not be severe, and very rarely would you require treatment in hospital for those infections.
But the risk of being hospitalized with an infection, as you say, I think it changes with time. I think that's a really good point. And it will actually change with the season. I think these are important points. And when you're on treatment for a prolonged period of time, your risk in every month is not going to be the same. But as you say, untreated myeloma in itself has a risk of infection. But we know from the trial data that the chance of being hospitalized when you're on this combination is increased by the risks of having low blood counts, which can happen if you're on a higher dose of lenalidomide potentially. And it may be that the risk of being hospitalized is maybe 10 to 15%. But certainly if you are older and you have other risks for getting infections like previous lung problems, for example, then your risk is higher. So I think when you're there with your doctor talking about infection risk, really, I think with the information that we know about you from your previous history, your myeloma and how you're responding, we'll try and give the best estimation of what your risk is likely to be.
Definitely. And I think we're planning on doing a separate podcast on infection.
Yeah.
So there will be more information coming through because this is a real concern for us all, particularly after COVID. But just one other thing really to add is it's also really important to keep up with your seasonal vaccination. So don't forget that your team in clinic, they're busy, they might forget to mention it, but certainly sense check it with them and make sure you're having your flu jabs every year and you're up to date with your pneumonia vaccination, for example.
With the drugs, the DRD combination, we have 1 injection and 2 tablets alongside the chemotherapy drugs, the injections. You have a bone strengthening injection, which is given once a month. And then there is other what we call supportive care, which goes alongside the chemotherapy to try and reduce the risk of potential problems or side effects. Sally, I already mentioned one, which was the blood thinning medication that people have because of the lenalidomide. What are the other support medications that people have?
This is quite a lot actually to contend with, because you think, okay, I can handle 3 drugs, but then you think, well, why have I got 10 then to go home with? So let's go through them one by one to help us all understand why they are so important. So steroids, first of all, can cause indigestion. And as we get older, I think many more people do suffer with this problem. It's not very pleasant, really, is it? So we offer a tablet to combat indigestion and decrease the likelihood of that. And if you have it, the severity. So that's in there. All of the treatments can potentially increase your risk of viral infections and in particular shingles reactivation. So we tend to prescribe an antiviral agent which lowers that risk. It doesn't get rid of it completely, but it certainly lowers it to hopefully combat that problem. At the very beginning, you might be prescribed for the first 12 weeks an antibiotic, and this is based actually on some data which came out of the UK some years ago, suggesting that if you have antibiotics for a fixed period at the beginning, then you fare better within the first year. So that tablet is called levofloxacin, but I think prescribing that, it's not necessarily available in every hospital, but just to say it might be there within the tablets. Then we come on to another antibiotic called cotrimoxazole, which is also called Septrin. This we recommend that you take you take it on 3 days a week. That tends to be Monday, Wednesdays and Fridays. And this can protect you from a particular lung infection. And your risk of this particular lung infection is increased because of being on steroids and having myeloma. So cotrimoxazole as well. At the very beginning, sometimes patients are prescribed allopurinol, which again, some of our listeners might be familiar with. This is a tablet which is often prescribed for gout. But in myeloma, we prescribe it at the very beginning of treatment to help protect the kidneys from slowing down as the drugs kick in and control the myeloma and destroy it within the body.
Yeah, it's a long list, isn't it?
It's
a long list. And I think people are often coming to us maybe with a couple of medications for high blood pressure or medication for other things that they've picked up. And, they're jangling, they're walking into clinic. Sometimes I think yesterday in clinic, actually, someone came in and showed me his dosset box, which is, these boxes that some people have for their medication, just because it allows them to understand what they're taking at what time. And he was like, look at this. I can't keep taking all these tablets. And it is hard. Calcium and vitamin D as well, Sally, which I think you were just about to mention, which goes alongside the bone strengthener. And sometimes people have a drug called fluconazole to prevent thrush, which is a risk of being on steroids.
Yeah, and I forgot as well, Jam, you'd already mentioned this, but a really important one as well, which is the blood thinner, of course, to protect you from blood clots. And the lenalidomide increases the risk of blood clots, so it's really important to be on a blood thinner if you're not on it already.
When my patient came in yesterday with his dosset box, he said, I'm just not going to take all of these anymore. Can you just tell me why I need every single one of these? And actually, at the end of the consultation, we'd actually stopped 3. So actually, he was on the DRD combination and the disease was under good control. And he'd been on it for a few months. He's sort of early 80s. And I was confident that he has a type of myeloma that is going to respond well and stay in remission for a significant length of time, probably another few years, like genuinely. We decided that we would stop the steroids because actually I think there is emerging evidence now, some very nice evidence that you can stop it after even maybe 2 months and people do very well. And we'll talk a bit to that, Sally. Because we're stopping the steroids, I said, well, you don't need the fluconazole because I think your risk of thrush is very low. And I don't think you need the cotrimoxazole antibiotic either, because I think actually your myeloma is under control. You don't have any other big risk factors for this infection. I'm going to stop this antibiotic as well. He was on a roll then and he goes, well, why don't we just stop the lenalidomide? Why don't we just stop the omeprazole? But actually, we did actually stop the medication to reduce the acidity in his stomach because we're stopping the steroids. So, 20 minutes later, 4 drugs down, I was like a hero.
Absolutely.
Which is always nice. Always nice for a few minutes. So I think that's just an example of how a consultation for someone on DRD whose disease is well controlled may look. But I don't know, Sally, what you think about my clinical approach to yesterday's consultation. Please be honest.
Well,
Tell me.
I hope you had a lovely high five at the end of that consultation.
I went in for a high five, but I was left hanging. It's just like my children. Anyway.
No, I totally agree. As you can whittle away at the drugs, and we definitely do that with almost everybody who's on this regimen. And by the drugs, I mean the chemotherapy, the DRD. As you stop those, you can stop lots of the supportive medication. So it does get easier as time goes by. But Jam, I just want to pick up on that really important point you've made about this emerging evidence and the role of steroids, or rather, maybe the fact that they may not have such a role in the future, particularly with this regimen. What have you heard? What's the latest data on that?
So our lovely colleagues in France did a really lovely study when they essentially looked at whether after 2 cycles of the DRD combination, if they dropped the steroids, what would happen to people and how long would the disease be controlled for. Now, they compared this to a group of people who had lenalidomide and steroids. So it was a comparison of these 2 groups. But essentially, what it showed us is that you can safely drop the steroids after 2 months. And the combination of just the lenalidomide and the daratumumab can work very well for, on average, around 4.5 years, which is, really excellent. And so much of the quality of life implications and the side effects of steroids have such a big impact on people that I think this sort of information, has, immediately been translated into practice in the UK in lots of areas. Specifically, this trial looked at people who were what we call frailer. And Sally, can you just expand on that a bit? Because we should just talk a little bit about that.
As people live with myeloma, as we live our lives, everybody, we can acquire medical problems or injuries. And some of those injuries or medical problems mean that we're just not able to do so much. And you can sort of objectively assess what somebody's able to do. And one of the ways you can do that is by trying to figure out if they are deemed to be fit. They're running marathons, less fit, so they're not able to run marathons, but they're still able to go out shopping, can look after themselves and so on. Or frail, which is those people who might be older, but not necessarily so, but because of other health needs or other issues in their life, perhaps aren't able to look after themselves as much as they'd like to. So we can objectively determine if people are what we call fit, unfit or frail. And what's really important about this regimen is even for people who might be unfit or frail, so less able to do day-to-day things in life, this triplet combination, the daratumumab, the lenalidomide and dexamethasone, still has an improved outcome versus lenalidomide and dexamethasone alone. So frailer people do really well on this treatment. And in fact, when you look at the quality of life data, so this is a way of trying to objectively assess or look at how people are feeling, literally, what's the quality of their life? What you tend to see with this treatment is the longer people are on the treatment, the better they feel, the better their quality of life. And in fact, there's some suggestion that older people have the greatest benefit. And by older, I mean those who are older than 75. So if you're older, even if you're not quite so fit, certainly not as fit as you once were, this treatment can still work really nicely for you, keep you well for a number of years, and hopefully improve how you're feeling and your quality of life. So really, really heartening data to know that just because you're not quite as fit and healthy as you once were, it doesn't mean that you can't get the best treatment that's available.
Right, I've got a couple of difficult questions for you now. Again, this is all from clinic actually in the last week. What happens if someone says to you, it's like, I'm not staying on treatment for 5 years? I mean, we should make the point that after really 6 months, you may just come in for an injection, this daratumumab once a month, and you have your tablets, and it might be really quite a light touch of how much time you have to interact with the hospital and doctors and medical services, which is good. We want people to not have to deal with the whole medicalization of their life. But if you are on current and continuous treatment, there will always be an element of medicalization of your life. And for some people, it's fine. And for other people, it's like, well, I'm just going to stop treatment. And then when the myeloma comes back, I will restart treatment. Now, is that okay for some people? Are there some people where you think that's probably fine? Or in most situations or all situations, would you say, look, I really think you should stay on treatment until your myeloma becomes more active? I mean, I get annoyed when I have to take antibiotics for a week. So I can't imagine what it is to be on just, treatment, every month over and over and over again
Yeah, I mean, this is a whole other conversation, isn't it, really, Jam? But an incredibly important one. I mean, of course, the first thing I would do is try and figure out what the treatment means to that person. Is there a particular reason why they want to stop? For example, do they want to go on holiday for a couple of months and they really don't want to come to clinic because they'd really much rather be on holiday somewhere lovely? Or is it because of the side effects of the treatment, or is it because of other issues in their life? But I think it's our job, really, to talk to our patients, hear what their wishes are, and then explain what we understand about the disease and about the treatment and what that might look for them. So I think I would certainly support somebody if they chose to stop, as long as I had shared with them what that might mean for them. It's taken almost as a given, is that if you do stop treatment early, it's probable, which means it's more likely that your myeloma will come back a little sooner.
Yeah.
And we're also a little bit limited in the NHS in that we can only stop treatment for a period of time unless there's a very good reason, like someone's really sick or they've had an operation. And we don't have the luxury of saying, okay, we're going to hold it for 3 months and then we're going to start it again. Unfortunately, the way that the drugs are funded, we're not allowed to stop and start according to somebody's wishes, which is a great shame, but I think that is based in good evidence.
Thank you, Sally. That's a really good answer. I think it's absolutely correct, isn't it, that if you do stop earlier, the myeloma will come back sooner, but it may not necessarily translate to you living less time. And that is a discussion that I do have with certain people. Clearly, for some patients, I think staying on is absolutely the right thing. And it works for them, and they fit it into how they live their lives. I think we shouldn't underestimate, and we should highlight to our listeners that we really do dose reduce quite a lot. And people start on 3 drugs at certain doses. Often the steroids go first or are reduced more quickly. The lenalidomide dose often drops down. And the thing that remains constant, because it is the thing that has the least side effects, is that monthly Daratumumab injection that can, carry on for a length of time. I mean, I saw someone yesterday, it's in a slightly different context, but he was on his 65th dose of Daratumumab. And, you see this drug and you see how well it works for some people with certain profiles of myeloma. And it's great.
Definitely. And it's a game changer. This class of drugs are game changers in terms of the number of people that respond to treatment and how long the treatment works for. So really great drugs. Jam, I just want to pick up on one other thing, which I think it does warrant a minute or two of explanation, which is the diarrhea piece that you spoke about 10 minutes ago that goes with lenalidomide. And the reason I want to mention this is I wonder sometimes if we're not on the ball enough about this in clinic, because diarrhea with lenalidomide is quite specific and can be quite problematic when it occurs. And it doesn't occur in most people, but when it occurs, it can actually make you really, really want to run to the loo, like straight away, because of the way the tablet affects the body. But it's also really important to say that if you do have that problem, it's often due to a condition called bile salt malabsorption, and it can easily be remedied with some bile salts, which you take every day, and then the diarrhea settles down and you stay on the lenalidomide. So please don't forget to mention that to your team if you are experiencing that problem. And that's not necessarily a reason to stop the treatment, we just need to manage it.
A symptom that has a massive impact on quality of life, but can be managed appropriately with the medication that you mentioned, Sally, and potentially tweaking the dose as well.
Definitely. And then guess we're coming to the end of this podcast, but I think we should wrap up because we haven't shared again those joyous steroid side effects, Jam, and I'm going to leave that one with you. Do you want to go through what I call the head, shoulders, knees and toes, but how you describe the steroid side effects?
We've gone through it a number of times in different guises, and I think it is important to go through it again, but I just wonder whether I should make up a poem or a haiku or something to go through steroid side effects. But yes, the side effects, and they can be more pronounced in people who are older. Certainly side effects like changes in mood and insomnia and restlessness can be much worse in older people. More older people have picked up type 2 diabetes, so steroids can make your sugars and diabetes much worse, which can be a real problem. Increase the risk of cataracts, tummies, soreness and indigestion. It can cause swelling or edema, which again can be more problematic if you're older, because if you have varicose veins or your blood vessel system isn't quite as good, you're more likely to get swelling. Can also cause what we call myopathy, so weakness of muscles, increased appetite and general weight gain. So, it's a combination of things that isn't very nice, clearly. And the great thing is that for certain groups now, we do know that we can really reduce the dose quickly, and for some people maybe completely stop after a couple of months. So, Sal, anything else to mention about this 3-drug combination before we wrap up today?
Well, one other thing actually that we do have to spend a lot of time speaking about in clinic is what we call, the medical word for this is teratogenicity. So what that basically means is that lenalidomide, because it's related to thalidomide, can harm unborn babies if an unborn baby is exposed to it. And that's either because a woman who's pregnant takes a tablet, or a man takes a tablet and then has sex with somebody, and that woman becomes pregnant, and it passes through to that fetus. And we have to fill in the forms regardless of age, exploring who somebody may or may not choose to have sex with, not the individual, just, to explore the risk of a woman becoming pregnant, and what contraception might be important, or if somebody's going to abstain altogether. And so it's a really important side effect regardless of age, and you will be asked about it in clinic. You will be asked to sign forms about it in clinic to make sure that, the risk of that ever occurring is as low as possible.
It's important, and it's something that we do spend time talking about in clinic as well. In summary, it's a great 3-drug combination. It works very well for lots of people who have myeloma and they are not proceeding to a stem cell transplant. We're able to reduce or stop a number of the drugs after a certain length of time for certain groups of patients. And we can hope that on average, people may stay in remission or have their myeloma under control for around 5 years with this combination, Sally.
Yeah, it's great. It's a game changer. And for those of you on it, get in touch with us and let us know how you're getting on, and keep those conversations live, I would say, with your clinical teams. Just in terms of, do you really need all the treatments that you're on, and how well is it working? And I really hope it's going well for everybody out there.
Thank you, Sally. It's been great chatting to you today, and I look forward to our next podcast. See you soon.
Yeah. Bye.
This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.